Good morning. So I'm going to talk first about diagnosis, features and the name of the syndrome. So, as Rob said, there'll be plenty of time for discussion, and just to highlight that I am going to talk about the guidelines. So this has only been discussed at a preliminary symposium at US Endo, so this is the second time that any of this has been discussed. And just to highlight that whilst the CRE was the primary funding group, ISAR and ISAR were the partner organisations, the PCOS Society of India was one of the important groups that were involved. In terms of PCOS, I'm sure you all know and are very familiar with this, but we know that genetics and lifestyle both contribute, and Rob will be talking about genetics later in the meeting and I'll be talking about lifestyle. These two factors contribute to hormonal changes, along with ethnic differences, which again Chandrika will be speaking to you about later. Any degree of obesity or excess weight then exacerbates the problem, leads to hyperandrogenism, hyperinsulinemia, and the clinical features we see, including hirsutism and acne, disruption of ovulatory function and infertility, and metabolic features, which are a particularly prominent problem in the Southeast Asian community. These then lead to psychosocial issues around body image, low self-esteem, depression and anxiety. The other challenge with this condition is not only is it multifactorial in cause, but it varies across the lifespan. So if you see a young girl, she often has problems with menstrual disorders, acne and hirsutism, and her requirements and manifestations of the condition and priorities will change as she moves across the lifespan. So what about the diagnosis? The most important thing to note is that the guidelines have not changed the Rotterdam criteria for diagnosis, but we have significantly changed the way we recommend they are implemented, and it will change practice internationally. I'm not going to spend I'll just briefly introduce the guidelines beforehand. I'll talk a little bit about them tomorrow when we're talking about evidence synthesis. But suffice it to say, it was a very rigorous process before we got to our recommendations about changes in the way the diagnostic criteria are applied. So the original NIH criteria was oligoanovulation and clinical or biochemical hyperandrogenism, with exclusion of other causes. We're all very familiar with that more severe traditional phenotype. However, in 2003, the Rotterdam consensus, which was exactly that, a consensus, added polycystic ovarian morphology to the criteria. And we needed 2 out of 3 of these criteria for diagnosis. Now, at the time, it was very controversial for many reasons, but I can tell you it's probably even more controversial now, because with the improvement in ultrasound technology and the improvement in the transducers and the probes, almost everybody can find PCOM, especially in young women. So we've had to revise the criteria, both the way they're applied and the follicle number per ovary, to be able to come up with a rational way of applying these criteria. The NIH endorsed the Rotterdam criteria in 2012 at a workshop that Rob and I attended, and subsequently so has all of the international guidelines and the most recent, which is the only true international evidence-based guideline. So when we started this journey, there were many reasons why the government did give us funding, and it was quite substantial, and why ASRM and ISRA partnered, both financially and in terms of their contribution. It is quite a complex condition. It has significant health and economic burden. It's intricately linked to obesity, and in countries with major obesity prevalence, the rise in obesity not only increases the diagnosis of PCOS, but it also increases the severity. There is evidence in this, because of Duru's involvement and the PCOS Society of India, we have Indian data in this as well, but we've published extensively internationally, and women affected by the condition commonly report delayed diagnosis and almost universally report a poor diagnosis experience. Most of them are diagnosed before they come to you, or by the time they come to you, they're pretty unhappy that they haven't been diagnosed before. Emotional well-being, they report, is fairly neglected, and as is metabolic risks. So the report of women is if they go to a dermatologist, they have their hirsutism treated. If they come to a reproductive endocrinologist or OBGYN, they may have their infertility treated. If they go to a family practitioner, it's highly variable. And if they go to an endocrinologist, they may be more concerned about their diabetes risk. But they don't get all of the conditions or the problems addressed or education provided across the board generally. And that's data from around about 2,000 women around the world, actually. They report inadequate patient information, generally poor satisfaction with care because of the reasons I highlighted. They may get very good reproductive care or very good care for their hirsutism, but they don't get the full hand. The prevalence does vary by the way the diagnostic criteria apply, but there's a recent systematic review that's looked at this, and it's between about 8 and 13% in the community and higher in obese populations and high-risk groups. For example, in the Indigenous Australian population, where obesity is 80%, the prevalence in those women is 1 in 3. Management is generally inconsistent, and there is evidence of a priority for health professionals for better education. And often the ethnic differences are poorly appreciated, and we'll hear about those relevant differences from Chandrika later today. So in that context, as Rob said, in fact, I think that this really kicked off as a collaboration when Rob and I flew from Melbourne to Washington to the NIH meeting. It took us 32 hours to get there. We were there for 30 hours. We turned around and it took us 32 hours to get home. But what that did do is give us 64 hours sitting next to each other on an aeroplane, which is a dangerous thing, because we came up with a huge vision and we spent the last 5 years delivering it. So we thought we would not half do this, and I am a very strong believer in large-scale partnerships. So we started this as a partnership, and Rob and I have worked closely together. We've engaged health professionals. As Rob said, we'd done it in Australia, but this time we did it around the world. And we also did the same with patients and consumers through major consumer groups internationally. We spent considerable time framing the problem from different people's perspectives. What did health professionals want to know? What did women want to know? Not just what the academics wanted to tell them, which actually is not the same thing. Scoping what was most important and prioritising it. Then we undertook a knowledge synthesis and systematic reviews and the international guideline. That little blue box there took 18 months and a great deal of effort, with 70 systematic reviews and 72 world experts involved, with meetings on 3 continents and with representatives from 5 continents. I'll tell you a little bit about that. We're currently in the stage of doing resource development and translation, and you'll hear a bit about that, and an international awareness campaign which will kick off with the actual formal launch of the guidelines and evaluation of the outcomes. So to start with, as I said, we had focus groups with women and health professionals. It's actually now about 3,900 women and health professionals we've surveyed around knowledge gaps, diagnosis experience, management, priorities, what clinicians and what women wanted to know, and how they wanted that information shared. I don't know how many of you have actually picked up a whole guideline and read it from start to finish. To give you an idea, our evidence synthesis review is 2,000 pages. No one will ever read that except me. Maybe Rob, but probably not even. The actual formal guidelines are 190 pages. Again, I doubt many people will read that. But the resources for our primary care providers are 2-sided flip-page colour charts that they designed. And we've done this before when we did this in Australia. That resource has now been downloaded 64,000 times by healthcare providers, and in fact half of them are from overseas. So the actual resources that we get this information down to are designed for clinical use. And as I said, both our health professionals and consumers involved engagement in India. So in terms of the groups we have involved, these are the 44 organisations who formally engaged, reviewed and endorsed the guidelines, and you'll see the list there, and that includes Aspire and the PCOS Society of India. From these societies we had 70 nominated people involved, quite a few of whom were world leaders, but many were just frontline care providers. So we had primary care providers, allied health professionals, and women involved in every one of the guideline development groups. So what is, and before I give you the diagnosis recommendations, what are evidence-based guidelines? Really important to understand what they're not is just what the evidence in PCOS tells us. And the reason for that is we don't have enough evidence in PCOS. So yes, we do rigorous searches for the evidence from PCOS, but we also have to bring in clinical expertise in areas where the evidence is not strong enough. We also bring in consumer perspective and, if we can find literature on it, cost effectiveness. But the evidence from research can be both from PCOS and for broader populations, for example, in general infertility treatment or in general prevention of diabetes, where we don't have PCOS information. So this is the activities we've gone on. And indeed, I've just been asked to lead a task force for the US Endocrine Society, because we took them through this process and they realised they do nothing like this when they develop their guidelines. The US Endocrine Society primarily does what's called clinical practice or eminence guidelines. In other words, they get a small group, usually of US experts, who tell us all what they think. They don't necessarily actually follow the evidence. So they've now decided to follow a very similar process, and for my sins I get the joy of doing the work with the task force, but hopefully the US Endocrine Society guidelines will engage other countries more often and will be more inclusive. So we established our guideline development groups and took a long time to scope what was important, so that we did a systematic review of the evidence. That should be the same no matter who wants to develop a guideline, and it's 95% of the work. So if people wish this information, it's freely available. We then formulated the guidance with multiple face-to-face meetings over several days in different continents, which Drew attended, and Chandrika and others from Asia, Southeast Asia. We are now at this level where we've had review from the 44 societies, and now we are just finalising the approvals. So very quickly, these are the guideline development groups that were prioritised. So diagnosis, emotional wellbeing, lifestyle and models of care, medical treatment and infertility. So from all of that, what have we done with the diagnosis? Well, we all know that the keystone for this in terms of diagnosis is irregular menstrual cycles. If it were just that easy, it would be fine. In adults, the irregular cycles to reflect ovulatory dysfunction are less than 21 days or greater than 35 days ongoing, or less than 8 cycles per year. But we can't apply those same criteria in adolescence, because the normal physiology of puberty, things are changing, and if we apply those criteria, then most girls immediately post-menarche would meet these criteria. There is concerns amongst the paediatricians that this condition is being overdiagnosed, and they're actually making an effort, including their recent guidelines, which were not very good, but they did not follow true strict evidence-based process, came out with a recommendation that it was less than 21 days or greater than 45 days. And that was for all adolescents. If you apply that criteria, by the time these girls get to 6 or 8 years in gynecological age, post-menarche, only 2.5% of them meet those criteria. And yet this condition has a prevalence of 10 to 13%. So it's actually not consistent with a diagnostic criteria approach. So we had all the paediatricians who were leading on the paediatric guideline involved in this, and they agreed that was a problem with the guideline. And so it's been updated, and I'll take you through this. So basically, in the first year after menarche, all bets are off. Cycles can be quite irregular, and that's the time where we don't diagnose PCOS based on irregular cycles. From 1 to 3 years post-menarche, it's less than 21 or greater than 45 days. And even the evidence for that is a bit challenging, but that's a safe level to prevent overdiagnosis. But once girls are more than 3 years in gynecological age or post-menarche until perimenopause, it is the standard less than 21 or greater than 35 days. The other criteria was added was if anyone over the gynecological age of 1 year post-menarche who has cycles that are longer than 90 days, not due to other causes, or those who have primary amenorrhea, with the diagnostic criteria you're familiar with, should be assessed for PCOS and where appropriate diagnosed. So these are slightly more complex, but it really gets around the problem that was there originally with the blanket rule about either just 21 or 35 days, which is what we do with adults, or 21 and 45 days, which currently is what survives for adolescents. So essentially, in this scenario, we recommend that they be further assessed for PCOS, and that you do consider when the optimal timing is for diagnosis in these young women. But if you do wish to start oral contraceptives before they have a formal diagnosis, because they're in the early postmenarchal phase, that's reasonable, but they should have a reassessment plan in place. The problem is when you get a lot of paediatricians together in a room, all they're worried about is not overdiagnosing, but they don't see the women at the other end, as you do, who haven't been diagnosed and haven't been given the opportunity for prevention and early treatment. So the other criteria include clinical hyperandrogenism, distressing, significant concern for women. The most important thing about hirsutism is how the woman perceives it. I'm sure you've all seen young women who look quite hirsute and are not worried about it at all, and some women who look positively nubile. I can hardly see any hirsutism, but for them it's devastating. So it really is, in this case, much more about their perception, because it affects their body image, self-esteem and quality of life. So we use the modified Fuhrman-Galway score to assess their hirsutism scores, and there is ethnic differences in these cut-offs. This was one area where the evidence was just not quite good enough, and in fact it's the only criteria that we are just still finalising on the exact cut-off. We've actually sent 3 groups who've published around the world back to reanalyse their original data set to give us a better idea of the cluster analysis so that we can really come to the fore. The group who've done this the best are actually a group in China who've looked at the Fuhrman-Galway score compared to all the other features of PCOS and done a very good cluster analysis, and we've now got those other groups internationally doing the same. So that the exact cutoff will be determined probably in the next 2 or 3 weeks, but it's likely to be lower than in the past. It's more likely to be a Fuhrman-Galway score of about 4 to 5 rather than 6 to 8, which it has been in the past. Female pattern hair loss is something that is often not seen in isolation in PCOS, especially not in adolescents. In adolescents, the hair loss is usually genetic or for other reasons, but in women who are older, female pattern hair loss can be associated with hirsutism and biochemical hyperandrogenism, and can therefore be a feature of clinical hyperandrogenism. What about biochemical hyperandrogenism? So this is actually relatively simple in terms of the evidence. All we need to do is assess a free androgen index or free testosterone using relatively high quality assays. So the guidelines actually recommended mass spec or extraction immunoassays with a calculated value. The big point here is that these women are insulin resistant, low SHBG and high available testosterone. It's actually recommended that we do not use free testosterone assays, direct testosterone assays, not direct free, that should say direct testosterone assays, even in low resource settings, because they're worse than flipping a coin. Androstenedione and DHEA and DHES are not required in the diagnosis. But we've also noted that, in fact, the most important thing is to look for the clinical signs first. If you don't find them, you can explore the biochemical signs. This is an obvious statement for most people in the room, but the number of primary care providers who try and assess androgens in women on the pill is perhaps a little surprising, but they can't be assessed accurately. And obviously, if they're markedly elevated, other causes need to be considered. So what about ultrasound? So, one of the important changes in the guideline, and this was unanimous in the end, is that ultrasound should not be used for the diagnosis of PCOS in adolescents, and that's defined as a gynecological age of 8 years. So girls who are post-menarche for the first 8 years should not involve ultrasound in the diagnosis of PCOS. Different if you want to do it for pathology, but the presence of multifollicular ovaries at this age is anywhere from 65 to 80%. It's simply not a useful diagnostic criteria. The threshold for PCM needs to be revised as the ultrasound equipment improves, and age-specific cutoffs do need to be defined as that happens. Transvaginal approach in ultrasound is important, and if we are using a transducer frequency with greater than 8 Hertz, then the threshold for PCOM, the evidence now suggests, should be around 18 per follicle number per ovary in either ovary, and or a volume of greater than 10 mils, assuming there's no corporal luteal, cyst or dominant follicles. The other important difference is that we recognise that if you have a woman who has irregular cycles and hyperandrogenism, she does not require an ultrasound. So if you wish to, again, do an ultrasound for fertility purposes, for pathology, absolutely appropriate, but in the diagnosis, an ultrasound is not required. And one of the strongest voices in the room around this was women. They said, why should we have a test that doesn't necessarily add to anything? It may, in all fairness, in a research setting, give us a full phenotype, but at the moment it doesn't change our clinical practice until we come to infertility treatment, which is not where we're talking about diagnosis. So, in terms of the other recommendations about PCOM, we made a very strong plea for clear protocols around reporting, and we'll be working with Duru and others to try and have this implemented more broadly, so that the last menstrual period, the transducer frequency, the root, the total follicle number per ovary, the 3 dimensions of each ovary, reporting on endometrial thickness and on other pathology, so that this actually becomes more of a standard reporting template. The reason we came to these recommendations is multifactorial. We know that at the moment PCOM is involved in the diagnostic criteria at any age, despite the significant problems with it in adolescence. But the literature in this area is really suboptimal. Polycystic ovarian morphology has often been tested in women with PCOS versus controls, and almost all the control populations have included women with PCOS who've not yet been diagnosed. There's real problems with age-specific normal data. The phenotype is quite variable. The statistical way this has been dealt with has been inadequate for a diagnostic criteria. It has the same problem I mentioned before. People just choose the 95th centile cutoff and say anything above that, think about PCOS. If you've got a condition that affects 10 to 15% of people, the 95th centile is an inappropriate cutoff, and you need to do cluster analyses, which have not been done adequately with PCOM. But the real problems are the technical issues and the reporting, which really makes, in many cases, probably not in the hands of people in this room, but in the hands of most providers, are not a particularly useful test in the diagnosis. And this is the cutoffs that have changed over time with the improving technology. So, importantly, these are not cysts, they are, as you know, arrested follicles, but women don't know that because this is called polycystic ovary syndrome, and I'll be talking about that shortly. It is not specific for PCOS, it varies dramatically across the life stage, so it's almost normal in adolescence and it's almost absent in perimenopause, and obviously is in menopause. Major technical challenges. So we are not recommending it in adolescents greater than 8 years post-menarche, and it is not needed in adult women if they have the 2 other features. So what about AMH? If we're having so much trouble with ultrasound, and again, remember ultrasound has its important role in fertility assessment, in ovarian and uterine assessment. We're just talking about diagnosis here. So women involved in the guideline were very excited to think a blood test might take away the need for an ultrasound, but we can't tell them that yet. So AMH should not be used as an alternative for the detection of PCOM or for PCOS yet. And we make the point in the second one that as the assays improve, this may change. There's some very large studies underway at the moment which we anticipate may change this, but at the moment it is simply not adequate to replace PCOM in the diagnostic criteria. So if you have a woman in front of you for PCOS, how do you assess and diagnose her? Most importantly, take a clinical history of her irregular cycles and of her clinical hyperandrogenism. It is recognised that 10 to 20% of women can have regular but anovulatory cycles, and so if you do suspect this, obviously, as you know, you can assess with progesterone levels, but this can be difficult in women who are anovulatory. For the androgen profile, just the free testosterone or free androgen index is important. SHBG in itself is obviously important in the calculation of free androgen index, but you do not need the other androgens. Exclusions of secondary causes is simple: thyroid function, prolactin, 17-hydroxyprogesterone, and an FSH level, clinical history and examination. In terms of ovaries, most of the time we now do not need to assess the morphology. We shouldn't be assessing it in adolescents, and in adults it's a third-line test, and AMH is not recommended. So if you have someone in front of you, step 1, check if they have irregular cycles and they meet the criteria, check for clinical hyperandrogenism, exclude other causes, and you have the diagnosis. If you don't have clinical hyperandrogenism, then you can check for biochemical hyperandrogenism and you have the diagnosis. If either one of hyperandrogenism or irregular cycles are not there in adults, you can then check for polycystic ovarian morphology. So it's a simple algorithm, and I haven't quite got the diagram the way I want it yet, but we'll get it there. So they're the diagnostic criteria, but what about the features? So we know, and this is one of the largest studies, this is actually from Western Australia, from one of our colleagues in the CRE, Roger Hart, and this is a long-term study of women who had PCOS over several decades. They do have a higher prevalence of endometriosis, much higher prevalence of gynecological procedures, high prevalence of hysterectomy, clearly high prevalence of infertility, of miscarriage and of IVF. They're also quite insulin resistant. This is actually data from our group on WHO criteria on CLAMP. HOMA is a useless test of insulin resistance in PCOS, as is fasting insulin levels. So please don't use it in any way to reflect clinically or in research what's happening with insulin resistance. But on WHO criteria on CLAMP, this is the normal range in our background population. Lean PCOS women, 75% of them actually were insulin resistant, and obese, well-characterised controls were actually lower than that, 65% were insulin resistant. And if they're overweight and they have PCOS, then they have insulin resistance, basically. So, are they more likely to be obese? And the literature, and again this is from one of our postdocs, it's a systematic review looking at the evidence of increased obesity, and there's a much higher prevalence of obesity and a higher prevalence of central obesity. Much higher prevalence of gestational diabetes, both BMI and non-BMI matched, so it's an independent observation related to PCOS aside from BMI. Type 2 diabetes, and this is just the BMI matched data, so independent of BMI, these women have a fourfold increased risk of type 2 diabetes. Cardiometabolic features are really controversial, and we won't focus on them for too long today, except to say that it's very clear gestational diabetes, IGT, and diabetes is increased. And if you've got a high-risk ethnic group, like the Southeast Asians, that's very important. Whether there's an increased risk of cardiovascular disease, we really can't say as yet because we just don't have the appropriate data out to the appropriate age ranges. This was the data again from Western Australia. So they do appear to have increased hypertension, ischemic heart disease, and there is actually several studies now showing significant increases in asthma, most likely related to the inflammatory nature of the condition. And there is multiple studies showing increased mental health disorders. So if you're going to look for other assessments in PCOS, we have changed the guidelines somewhat based on the fact that our Nordic colleagues were very adamant that they had a very low metabolic risk population and wished to make the recommendations for metabolic screening based on their data alone primarily. But it was very clear when we pointed out that 60% of the world's population is from Asia and has a much higher metabolic risk that we couldn't make recommendations based on a Caucasian lean population. So we compromised, as we have all the way through the guideline. And basically, if you are lean with PCOS and no other risk factors, then fasting glucose, that should say, or HbA1c can be done every 1 to 3 years from diagnosis. If you have any additional risk factor, including Southeast Asian ethnicity or obesity, then you need a glucose tolerance test. And there are many reasons for that, which we can discuss as needed, but it is actually a much more appropriate test in PCOS. There is no role in clinical practice for insulin levels. They are simply too inaccurate. If the woman walks 300 metres, has a blood test, it'll be completely different to if she sits for 20 minutes in the room before she has the assay. Before she has the test. So they're not currently accurate enough. The other problem is that in PCOS, the insulin resistance is skeletal muscle, which is related to glucose uptake. It's not hepatic insulin resistance till they become obese, and hepatic insulin resistance is more related to fasting glucose abnormalities. We do recommend that because they have a high prevalence of obstructive sleep apnea, if they have clinical features only, So if they are fatigued, they have daytime somnolence, they snore, and especially if they're overweight, then it's reasonable to screen them for OSA. But please note, there is no evidence in the general population at all that treating obstructive sleep apnea improves insulin resistance, diabetes or heart disease. And there are big studies now that have done it. So originally everyone was worried about OSA, obstructive sleep apnea or PCOS, screen it, treat them with CPAP, and you'll help the metabolic features. There is no evidence for that. So yes, it does occur in women, but the only indication to screen and pursue it is if they've got symptoms. For endometrial cancer, the most important thing is to be aware of the increased 2 to 6-fold risk, the fact that it can happen premenopausally, and that prolonged amenorrhea is a risk factor and prevention should be instituted. The other area, and I'm not going to highlight this because Chandrika is going to talk to you about it, but the guideline does focus on the fact that there is evidence for geographical variation. Caucasians actually have a pretty mild phenotype until they become markedly obese. And I'd say that's the same for many conditions, including gestational diabetes. In our services, I can sit in a room with typically a group of women with GDM. The mean Chinese BMI in our population is 22. The mean Southeast Asian population BMI in GDM, and this is over hundreds of thousands of pregnancies, the mean BMI in Southeast Asian women is about 25, and the mean BMI in GDM women from Caucasian background is 32. So clearly the BMI these women need to get gestational diabetes is very different, and yet we treat them all the same. We give them the same dietary advice. But the point is that Caucasians have a relatively mild phenotype, and it's primarily manifest when they're obese. There's more severe hirsutism in Mediterraneans and in some other countries in the Middle East. There's increased central adiposity, insulin resistance, diabetes and metabolic risks, and more acanthosis nigricans in Southeast Asians. I'm sure Chandrika will talk about that. And Indigenous Australians are particularly at risk. Lower BMI and milder hirsutism in East Asians, and in Africans higher BMI and metabolic features. So it can vary through different populations. Psychological features and quality of life is also really important. I can tell you that I could almost write a book about the feedback that we have from the 44 societies about the guideline. So what happened was we sent the guideline out to the 44 groups, and they all had special interest groups who formed to provide feedback on the guideline, and they were very diligent and it was exceptionally useful. I had to wade through 500 and something comments, and in many cases we did revise mainly some of the wording in the guideline. But it was really interesting because a lot of the professional, especially specialty societies, made comments like, can you take all the reference to the psychosocial stuff out? It's fluff. We just want the evidence about the medications. And then the women's groups who were interspersed between the professional societies were, thankfully someone's acknowledged all the psychosocial challenges with this condition. Finally someone's actually listening to us. So it was really an interesting contrast. But the psychosocial problems can be quite marked, as I'm sure you know. The evidence shows significant prevalence and severity of anxiety and depressive symptoms. They do have an increased prevalence and severity of anxiety and depression through formal diagnoses, but most of these women have symptoms that don't quite meet clinical criteria for anxiety and depression, and are often related to the distress of the condition. In that case, working through and treating the features of the condition, for example, hirsutism or the infertility, can help allay that distress. They often have poor body image. There is now, on a systematic review, good evidence of psychosexual dysfunction. They have higher rates of disordered eating and eating disorders and impaired quality of life. So we focused on emotional well-being in this condition in the guidelines, took a holistic and positive view of health for the reasons that if we don't, it will impact on physical and health and self-efficacy. It's obviously a challenge to feminine identity, and obesity and hirsutism and other clinical features of this condition affect the psychosocial issues. Also, there's a prevalence of much higher prevalence of mental illness, of formally diagnosed mental illness and PCOS. And there's recently some published literature on increased rates of bipolar disorder and also of borderline personality disorder in women with PCOS. So that psychological screening and treatment is important and was recommended in the guidelines for the reasons outlined, that they are more likely to have symptoms, that it's poorly recognised, and that greater awareness and screening and management is needed. We need to recognise also that women are quite diverse, look different and have different experiences individually, ethnically, culturally and across the lifespan. So we actually asked women what was most important for them with this condition, and I have got now data up to nearly 2,000 women, but it's almost identical, and this is pretty much the same no matter what country you're in, although I have to say the Nordic populations didn't struggle so much with losing weight, but almost all other groups did. So for women with the condition, their biggest challenge that they report, or the most important thing, is difficulty losing weight or concern about weight, and then irregular cycles. This does vary across the lifespan, and it does vary slightly on geographical basis. So I'm going to talk a little bit about now the name of the syndrome before I open it up for discussion. As Rob said, we've done quite a bit of work around this, and this initially started when I was invited to be involved in a debate entitled "This House Believes PCOS Needs a New Name." So we started this at an ICE meeting in Florence, and there was, I think, about 2,500 people in the room, and they had the touchpads to vote. We started at the start of the session, and 72% of people who voted said we really needed a new name for PCOS. By the end, around about the middle, it was about the same, and by the end of the debate it was down much further because nobody could agree on what name it should be. So I'll just take you through this work a little bit because it's likely to evolve. So we had done quite a bit of work around national surveys with our women around whether the name causes distress and what the alternative name should be. And we'd actually published that, and I believe that was actually in JCEM quite a few years ago. Then it went on to the next step, which was at the NIH evidence-based workshop, and the panel reviewed all the literature, including that publication, and recommended that the name is currently a distraction and an impediment to progress. It causes confusion, it's a barrier to education, communication with the public and research funders. It focuses on polycystic ovarian morphology, which is neither sufficient nor necessary for the diagnosis, and with the new guidelines will have a much smaller role in diagnosis. It doesn't recognise the advances that have been made, and they recommended it was time to assign a new name that really understood the complex condition, so that it could be recognised as a major public health issue, and there could be much greater awareness of the broader features of the condition. So they actually stopped short by a vote of 1 in just changing the name of the condition there and then, and if the NIH does that, usually it has some influence, and they were going to change the name to metabolic reproductive syndrome. But they didn't because they felt they had not yet had enough engagement with women. So we then went on to have an international consensus meeting. We had presentations, strong consumer representation. We explored the options. Should we not change? Should we change with more consultation around what we should change to? Or should we just change to the name that had come up in the research to date? We undertook a strengths, weaknesses and outcomes and threats analysis, and agreed that unanimously, with representation across all continents, that we should change the name once everyone could decide what that should be. And so we did international engagement around that and looked at their importance, what they thought we should do, and went on to have patient advocate surveys and also professional societies. And in fact, I'm not sure if the PCOS Society of India was involved in this one, but definitely the other surveys. So in this population with women, it shows you that the majority were around 26. Many of them had been diagnosed for a number of years, and this was mainly results from US, Canada and Europe. So this is what women basically thought. Most disagreed we should keep the current name. Most thought it was very confusing or misleading, but they also thought that education would be helpful. So this, in terms of what women felt, they felt the most important group for knowing what the name really meant and what the features of the condition were women who were affected, medical doctors and those in their family and friends. In terms of potential names, metabolic reproductive syndrome, surprisingly almost all of them agreed we should change it, but yet polycystic ovary syndrome came out as one of their options. But metabolic reproductive syndrome, or MRS, or MRS as it actually ends up coming down to, was the most favourable of the options. Amongst health professionals, and these were gynecologists, endocrinologists primarily, again, you can see the demographics here, and most were from Europe, Canada, and the US, but there was quite a number from Asia, and these were almost all from India and Australia and New Zealand. And what we found from this was actually very similar to the women. So most felt it didn't convey clarity, very few felt the name should be retained and that it was misleading, that it should be changed, but that education was also more useful. And in fact, what we probably needed was to change the name and have more education. They also felt that it was very important what this was named mainly for women. And usefully, they also reported that the preferable name would be reproductive metabolic syndrome or metabolic reproductive syndrome, and the conditions that have been suggested by some health professionals, including hormonal imbalance or any name that included hyperandrogenism, was very much out of favour with both groups. So in terms of different background groups, whether it was obstetrics and gynecology or endocrinology, there wasn't a really big difference in groups. Both of them were generally supportive of the main two suggested names. So the bottom line is, with all that process, that almost all groups agree we need a change. But the biggest problem is, although we have a reasonable consensus around potentially reproductive metabolic syndrome or metabolic reproductive syndrome, there is still a significant proportion of women who are not content with that, and in fact a fairly large push for a more generic name that they can relate to the condition but that doesn't label them as having one thing or another. They may not have reproductive features, they may not have metabolic features, and in fact many of the women actually favoured going back to the original Stein-Leventhal because it didn't label them as having one feature or another. But at the moment there is more engagement in this space, because we need to work with our international communities and our patient groups to make sure that they're on board with the final decision. Okay, so I've left some time for questions, and that was a bit of a whirlwind tour of topics. Thank you.